I want to thank you if you decided to join me for the final portion of this video. Again, this is about the incident that took place on November 3rd of 2015, in which my son Paul Robinson Jr. was critically injured, transported to a local hospital, and it is our belief that he did not receive definitive treatment. The information that I'm providing you with, I am not trying to present it as an authority, as a professional. What I'm doing is trying to share with you the information that has had us concerned over the last 2.5 years. And it's our belief that besides being well below the standard of care, what happened in regards to the Sheriff's Department, the County Attorney's Office, the Attorney General Office for Arizona, the local media, and my own personal experience here with healthcare has us very much concerned. And we believe that the sharing of this information will have you concerned as well. In this final portion that I want to share with you is our concern, besides the fact that we were not properly informed throughout this process. There seemed to have been a clear disregard for our son's rights and our rights, being misinformed, not informed, or what seems to have been manipulative conduct in order to make sure that our son became an organ donor. Let's go to the definition here of euthanasia. The term normally implies an intentional termination of life by another at the explicit request of the person who wishes to die. Euthanasia is generally defined as the act of killing an incurably ill person out of concern and compassion for that person's suffering. It is sometimes called mercy killing. But many advocates of euthanasia define mercy killing more precisely as the ending of another person's life without his or her request. Euthanasia, on the other hand, is usually separated into two categories: passive euthanasia and active euthanasia. In many jurisdictions, active euthanasia can be considered murder or manslaughter, whereas passive euthanasia is accepted by professional medical societies and by law under certain circumstances. However, in the state of Arizona, either is against the law. Maybe that's something here I can quickly pull up. So as you see here, Arizona euthanasia laws prohibit the practice of mercy killing, but allow for the withholding of artificial life support under certain circumstances. Euthanasia, suicide, or assisted suicide is not authorized or approved by Arizona law. All right, so let's go to the evidence. First thing I want to share to kind of put things into perspective would be, I want to go to a letter that we received from the hospital. Now this letter, give you some time. You might want to read some of it. I had been going to the hospital to get medical records. The last time that I went, well, I got the complete medical records once in January 29th, on my birthday, as a matter of fact, of 2016. However, I had made numerous visits because it appeared that records were missing, and some I will show you. In the record there are at least 6 pages missing, both from the trauma bay in the emergency department when PJ first got there, and then later on, along with 3 indications that PJ went for an MRI. Now, whether that MRI was an MRI of his brain or an MRI of the lacerated spleen, we don't know. It's not indicated in the records. But what is of concern is the fact that there is no record. There are no films of that MRI. There is the reference to him being taken there, and that's it. And that, in and of itself, is very suspicious. So this letter references, it says, this is from Chief Medical Officer of this hospital. And he says to me, it is my understanding that you expressed concerns regarding the medications listed in Paul's medical records. You share concern that morphine and Ativan were not present on the list of drugs. What list of drugs? There was no indication that he would be receiving those when speaking with the individual from Donor Network. That individual indicated the only other drug he would receive would be heparin. So that's the only list that I can think of. It says also, you are also concerned that both medications may have been rapidly pushed when administered, which would subsequently cause Paul's medical condition to decline quickly. You have asked that we review your son's medical record and provide our investigative findings. That's not true. I had no contact with those individuals. Again, the only people I had contact, the only person I had contact with was the medical records employee that I would have to make my request to. I never spoke with them. Now, when we get a little further down here, and this is extremely important, however, it's slightly faded. It says both medications were administered with his intravenous fluids at a low dose and slow rate until Paul went into the operating room at approximately, and this is important, 7:40 p.m. 7:40 p.m. Now, in military time, that would be 1940. I'm going to ask you to remember that time. 1940 is the time that they say that he went into the operating room. Now, it's our belief, and we were present. I was holding him. It was my belief and understanding that all cardiac activity had ceased. So essentially, by the time that he was wheeled into the operating room, he was deceased. Okay? It's important to remember that time. And it continues by saying our documentation also reflects that he did not receive an IV push of any medication. That's very important. Okay, I'm going to go to I'm going to go to the first document here. That seems to contradict this. This is an analgesia infusion record. And as you can see here, it says morphine bolus dose milligrams 4 at 2006. Now their own letter to me indicates that he was transported into the operating room at 1940. So this is 25 minutes later. 25 minutes after he's wheeled into the operating room, he received morphine 4 milligrams. Now I want you to keep in mind that there's no point in giving any IV solutions if there's no cardiac function, because it's not going to circulate. You know, so flag is flying. I've got more to share. Okay. Here's another one you'll find interesting. This is a blood component administration document, and it indicates that he had received blood transfusion on 11/23. But look here also, it says 12/1/2039. Also indicates OR and consent sign non-applicable. And then there's no other information after that. Now it was 1940 that they said he was wheeled into the operating room. And here there appears to be a note saying that almost an hour later he received the blood transfusion. How can you do that if there's no cardiac function? Okay, there's more. Let's go to this one here. All right. Keep those times. Stay mindful of those times that I just indicated to you. Again, this letter was the letter from the hospital was unsolicited. I never had any contact with any authorities within that hospital, only the individual and medical records. Now this is a document which indicates that on December 1st at 9:48 in the morning, an order was written for fentanyl. 25 micrograms, 0.5 milliliters, IV push, Q1 hour, routine PRN. The end time of this is 01:19 the next morning. This is the morning after PJ was deceased. That's the time that this order was DC'd. Let's go to the next one. Okay, this is an order, again, at the same time that morning, 0948. We had no knowledge of this. Nothing was discussed with us. This is an order for morphine. 2 milligrams, 1 milliliter, IV push Q 30 minutes. Discontinued time, 5:38. Now this is an individual who said, unsolicited, sending a letter to us, that PJ never received any morphine or Ativan or any drugs IV push, such as these sedatives or pain medications. But there are examples that this more than likely is not true. Oh, there's something else on here. Okay, here is another order the same morning. It says, start infusion at 1 milligrams an hour IV may increase by increments of 1 milligram an hour every hour for uncontrolled dyspnea, shortness of breath, or pain. Look at the end time. 12/2/0119 the next morning. Why? You can't get IV fluids if there is no cardiac function to distribute the solution. Okay, let's look at more here. Here's the an Ativan order. This is at 9 o'clock that morning again. Here's another example of IV push. 1 milligram, 0.5 milliliters IV push, Q 30 minutes. I'll make sure I'm not being redundant here. But if you look at the end time, it says if anxiety not controlled with intermittent dosing, initiate continuous infusion. Discontinued time, 5:38. Anxiety. Why would he be feeling anxiety that morning? And this is what I find troubling as well. There are some indications that there was some neurological function returning. To what degree and the meaning of it, I don't know. They also say that your hearing is the last thing to go. I can't think of any reason for him to be anxious at 9 o'clock in the morning. Unless there is some belief that he is aware of what's going on and what's coming. And I find that very troubling. Okay, let me stay focused here. The bottom order here says start infusion at 0.5 milligrams an hour IV. Contact provider for additional orders if patient does not appear comfortable. Action date and time. Discontinue 12/2/0119. That's the next morning. Now, I don't know if I showed the document showing PJ's potassium level at 4 was within normal limits. Here's an order for 40 milliequivalents or 20 milligrams of potassium chloride. The order time Now, I don't know why this says modified, or what was modified. But it has complete time is 1939. That's a time that I want you to keep in mind too. 1939, the letter indicated he was wheeled into the operating room at 1940. 40 milliequivalents. Well, I want to go. I want to go to the billing record, and this is what's important, the billing record, because these meds are checked out or scanned when they are given and give you a more clear understanding of what's given. Okay, let's look here. Here we have potassium chloride, 2 milliequivalents times 20 would be 40 milliequivalents, and it says injection. That primary bag. There's another example that indicates IV piggyback. But these are injection. And lidocaine is usually given with the potassium chloride when it's given as an injection to cut down on irritation of the veins. Here we have it. This is in the morning. This is in the evening. Now this is an individual that, from their perspective, or from their point of view, his life is about over. And at 4 o'clock, his potassium level was within normal limits. I mean, really, was there some concern that his potassium level might drop some? And so he gets such a high dose of potassium chloride injection, as indicated here. I want you to also look at morphine sulfate. 10 milligrams times 10 equals 100. That's 100 milligrams of morphine that's billed. Oxycodone, 5 milligrams, given here, given here, given here, given here. So between the oxycodone, morphine sulfate, would appear to be an order giving him fentanyl, and we have this. Here's an order for lorazepam, 2 milligrams times 50. That would have been 100 milligrams of Ativan. All right, that says primary bag. All right, then we come here, and it appears that that was canceled out, and they went from PB, my understanding is primary bag, to 2 milligrams times 10, which is 20 milligrams, injectable. Now it says here 100 milligrams of D5 dextrose in water, 100 milligrams, milliliters, times 1. One of the things that we have to keep in mind is what transpired in the beginning. How he was perceived in the beginning, no name, no identification, O positive, a belief that he was initially an illegal alien, then there was inference of him being homeless, but nonetheless This was an individual that could provide a lot of resources, both in terms of organ donation and revenue. We all know about supply and demand, and there is a big demand for donor organs. And an O positive patient can be seen as someone that can provide those organs to numerous people. So the question is, how far do you go? Now what we've seen here, what I've seen here, is a willingness to act with impunity. A belief that there is no oversight, and judging by our inability to get legal counsel in this town or any support from the media, any acknowledgement from the county attorney's office or the attorney general, you have no rights. You know, you're not seen as a sentient feeling person when you're an African American. Now, I don't know if it's any different with Hispanics. You know, they have the representation down here. We don't. Blacks don't. And if how I was treated, how my son was treated, his mother was treated is any indication, blacks are seen as irrelevant, and there's no respect for their feelings or their rights. Okay, let me get back to some other pieces of evidence here. I'm going to go to okay, let me go back here. This speaks about morphine and Ativan. Use of opioids and benzodiazepines, which is lorazepam, or other central nervous system depressants, sedatives, hypnotics, muscle relaxants, anesthesia, antipsychotics, and other opioids or alcohol may result in profound sedation, respiratory depression, coma, and death. Okay. So I've showed you the morphine, Ativan, fentanyl pushes, going over until the next morning. Let's go here. I showed you that he was billed for the oxycodone at 5 milligrams. Here is a notation indicating at 4 o'clock that afternoon, no actual or suspected pain. They're giving him the oxycodone. So what is the purpose of all the morphine, the fentanyl, and the Ativan, and the late potassium chloride? Why was it continued after supposed cardiac death? Okay, now I'm gonna go here. I just want to show you something about building the narrative. A narrative to support, that's not it. A narrative to support their agenda. Now, as I showed you with the CT scan, he had a 15 millimeter subdural hematoma with a 9 millimeter midline shift. Here is a note. During the time period when we were dealing with this neurosurgical ICU doctor that was in charge. Here is a note saying no brainstem reflex or neurological function due to extensive right epidural hematoma. Well, he didn't, according to the records, he didn't have an epidural hematoma. He had a subdural hematoma. It also wants to mention the posturing, neurostorming, and one thing I didn't mention. He got to the hospital on the 3rd. According to the records, he didn't have a bowel movement until I think they did an enema on the 13th. That degree of constipation could also contribute to, and I can say this from experience, sweating, chills, increased heart rate, blood pressure. But it does indicate that has a positive gag reflex. Again, this goes back to the fact of this neurosurgeon and those individuals in that emergency room. They created a precedence where everybody subsequent to them looked at PJ as a hopeless case. And I believe that you can understand how, if this person is considered hopeless, you don't have the same urgency or concern when you are approaching the work that you're doing with this individual compared to how you would approach it if you believe your actions were going to contribute to saving his life. So what that neurosurgeon did by saying no brainstem activity, no neurological function, and not compatible with survival was a death sentence. A premature death sentence, and a death sentence he didn't have a right to give PJ. His responsibility was to do everything in his power within that first 72 hours to give him the best chance to survive. But that was not based upon the facts, based upon the records. That does not appear to be what was their motive, their agenda. Because they quickly called donor network. Let me go through something here that I found. I went through, the first intubation and the document that seems to indicate that there was a second intubation and that no sedation or pain medication was given. I made reference to the Brain Trauma Foundation recommendations that decrease mortality with adherence to those recommendations that include the intracranial pressure monitor, EEG, repeat CT scans, patient-specific monitoring in order to treat that patient's conditions based upon the test findings, blood pressure, the intracranial pressure, cerebral perfusion pressure, and even the removal of the mass lesion, space-occupying mass lesion, to reduce intracranial pressure, or the craniotomy or the craniectomy to allow the brain to expand and to avoid herniation that can be traumatic to the brain stem and very damaging to the patient if that happens. Now this is from trauma.org, neural trauma, and let me see what is it I wanted to bring out in this. Let's go here. Okay, the two things that I want to bring out in this was one, the mannitol. Okay, mannitol is a drug that's given, and it says here it takes effect within 15 to 30 minutes, and it can reduce, let me read it here. Mannitol, therefore, best used by bolus administration when an acute reduction in ICP is necessary. Well, if this neurosurgeon was in the room at 21:23 and he did an assessment, a neurological assessment that led him to believe both if he did have extensor posturing and he had bilateral fixed and dilated pupils, then he knew that there was a good possibility of impending herniation. That's the time you give the mannitol. It's my belief that's when he should have received the mannitol. According to the records, he received it later, but why wait? It takes 15 to 30 minutes for it to take effect. And the priority has got to be to avoid secondary injury to the brain. The primary injury you can do nothing about. That took place during the accident, before he got there. But it is the secondary injury that's within their hands, within that golden hour. So why didn't he give the mannitol at that time, or order the mannitol at that time? There is nothing in the records that indicate he ordered the mannitol. It says neurosurgery contacted. It also shows a little note that says neurosurgery called. You don't call them if they're there. Neurosurgery called, mannitol given. Now, if he's seen him the first time at 21:23, any subsequent phone call to neurosurgery, since he did the initial assessment, would have been to him. You wouldn't call neurosurgery to call and speak to somebody else. You would call to speak to the person that was down there that did the initial assessment. I mean, that's what makes sense to me. So why in his notes at 23:50, which is 11:50, almost 2 hours plus afterwards, does he not mention that he ordered the mannitol? And that's part of the flags. Look at sedation and anesthesia. It says all of the most severely brain injured patients, Glasgow Coma Score 3. PJ, it's my belief that PJ, when he got to according to the records, was GCS 5, at the least 4, but he was not 3. He was breathing spontaneously. He had a steady heart rate, blood pressure, cough, gag reflex. It says all but the most severely brain injured patients, Glasgow Coma Score 3, will require anesthesia for intubation. The cardiovascular responses to intubation induce a rise in ICP. That's the pressor reflex. which is exaggerated in those patients on the cusp of the pressure volume curve. Now we get to, again, the rapid sequence induction. Rapid sequence induction is probably the safest method of establishing an airway in these patients. Why wasn't that done? They gave him lidocaine, but lidocaine is not has not been shown to really be impact that pressure response. And it is documented in some places that it's more effective as an oral anesthetic versus IV. But the fentanyl wasn't given until 2017. Now that is before the second documented intubation. And then at midnight, he started on propofol when a prior note indicated no sedation required. He's been in an accident. He's had a tube stuck up his urethra. He's had a tube stuck down his throat. He's had people trying to find arterial lines in his arm, putting arterial lines in his neck, putting in a chest tube through his rib cage in order to reinflate his lungs. All of that's painful, and there's no consideration of his well-being. This is suffering people. And when you get to a certain point with your suffering, you go into shock. And then that's reflected in your blood pressure. And his blood pressure appeared to drop after that second intubation. He received fentanyl. They increased the ventilator from 14 to 18. And it's quite possible. Again, the only time the neuromuscular blocking agents are in the record is at this 1022. So the question I have is, did they attempt an intubation without any type of neuromuscular blocking agents, sedation, at 21:28, and they did it wrong? And it was what's called an esophageal intubation. I mean, what's clear is you don't do it again if you did it right the first time. Okay, I believe I've gone through the drugs, the morphine, the Ativan. Let me show you some of these for the record. This reflects here are trauma notes, and you see it's blank. Now, there should be no blank areas here, because there's a chronological order to this documentation, and the only reason for a blank page, from my understanding, is if the substance of that page is removed, and that keeps the order flowing. In this case, from 2166 to 2167. But the substance of that page is missing. Okay, this one is a trauma note. Let's go to another one. He who controls the information or controls the narrative. ED report, emergency department. Blank. Why? Again, there's 6 pages between emergency department, trauma bay, and expiration documentation. There are 3 documents that indicate that he was taken for an MRI, yet there is no report and there's no film. Why? He received medications, morphine, Ativan, and according to this one, fentanyl, that were not discontinued until 1:19 the following morning. Why? He received blood products an hour after supposed cardiac death had occurred. Why? You know, I don't want to even speculate on any possibility that there was an attempt to revive him once he got into the operating room. But the fact of the matter is, if there is no cardiac function, there is no circulation, and having these IV lines and receiving these meds or blood transfusions, it makes no sense. We were misled when it came to what medications he would receive as part of this organ donation process. We have this troubling leader of this neurosurgical ICU team that made a comment about would like to hold off on the trach tube and the feeding tube because there was hemodynamic instability. But they created that hemodynamic instability by misdiagnosing that he had the upper respiratory infection, the ventilator-acquired pneumonia. They ignored that. They ignored the fact that he was constipated. But they needed that in the narrative to justify not moving forward with the trach and the feeding tube. Then they give him the propranolol, in which case one says his heart rate went down to the 20s, another one says his heart rate went down to the 40s. It's not in the flow sheet of his heart rate at any point going down there. Then this doctor puts in the record that he had a stroke. There is documentation on the cardiovascular edema. Caused how? By a nurse practitioner giving the wrong medication? This doctor puts in the record a stroke but doesn't tell us, and then doesn't document it, or doesn't document anything that was done as a result of this stroke besides we will discontinue that medication? Taking away our surrogate decision-making rights against the law. A HIPAA violation by discussing PJ's condition with this Carla against the law. Didn't intend to treat him. Totally disregarded and had no respect for the sanctity of PJ's life or our rights in the middle. Something that occurred to me. We don't have the right to say that PJ should not be a do not resuscitate. They override us on that. But they're going to respect our rights to make him an organ donor? At some point, after they have pushed this agenda on us, they've held up. If he had the trach and he had the feeding tube, he would have been in a skilled nursing facility and not an organ donor, period. So clearly this individual wanted to keep us from making that decision because they wanted those organs. This is troubling, people. What happened at the end, besides the loss of chance in the beginning? What happened at the end, according to state law and according to these documents, represented euthanasia, represented manslaughter. Many times I've had to, many times I questioned what I was seeing and how I was perceiving it. Then in July of last year, when I was going from an outside primary doctor to back to the VA, there was a delay in me getting an appointment. And I have dealt with chronic pain for 17 years due to spinal problems, disc problems, knee problems, fibromyalgia, some cardiac problems, gastric problems. So I'm told that the only way to get appropriate pain medication is to go to the emergency room, and I wasn't going to go to the VA. So I went to one of the local hospitals. First time I stayed in there, 2.5 or so hours, people are coming in, they're going back, and I'm still sitting there. And I go back to the window and I said, well, I've been waiting. People are going ahead of me. And they say, well, we don't have your name. That's after I sat there for over 2 hours. All right, so I leave, I come home. I go a week without pain medications, and I have to take NSAIDs, which I can't take because of these GI problems, but I didn't have anything else. So I go back. The second time I go back, I don't know, I'd almost call it I'm attacked. The nurse practitioner comes back into the room with another individual, and they're being very aggressive, trying to indicate that I had got medications. They have this system where they can check for any narcotics in the state of Arizona, if you got any prescriptions for it. And when I left my prior physician, I got refills on everything that I had refills on to tie me over until I got into the VA. But the only thing that I didn't have a refill on was my primary pain medication. And that's why I was there. So needless to say, they're trying to talk to me as if I'm a drug seeker. And, just really aggressive, talking down to me. And I'm trying to explain them in a calm manner. And then these are two white women. They both walk out of the room, and one of them says, call security. Well, I've been around long enough to know that in a situation like that, especially the sense that I'm getting about Arizona, two white women, I'm a black man, she's talking about calling security. They can build whatever narrative they want. So I get my things together, and as I'm walking out, the three of them, the security guard happens to be a white woman as well. They're all standing around a computer. And on my way out, I simply tell them, you're wrong. And I walk out the door. I would later find out that that nurse practitioner put in the record that I left against medical advice. All right, so I go back home. Another 2 weeks go by. Another week goes by. I call 911. I'm severely distended. I hadn't eaten in 2 weeks. The fire department comes. They take me to a hospital. The doctor does. Um, the doctor. I you know I I told him the story of what's been happening to me, and they got me sitting up in a chair. Um, Not a normal chair, but kind of a chair that they can kind of recline. And so they give me some type of weak pain medication. I asked them for a GI cocktail. That's Maalox and lidocaine. They give me that, and I sit there for about another hour, hour and a half. And what they had given me for pain was not helpful. I was extremely uncomfortable because I was extremely distended. And I get up and I walk to the counter to find out what's going on, and they're sitting there eating at the counter. And he says to me, I had scheduled you for an x-ray. Have they been there to see you? And I tell him no. And at that point, you know, you're not going to give me anything for pain. You're going to have me sitting up in a chair for an hour, hour and a half. You're just casually eating. So, I can be miserable at home. And so I go out to the lobby. I have no other way to get home, and I have to call a cab. So I go back home. Now I'm back at home, not eating, laying in bed. This is going on 4 weeks now. Not eating. I lost 21 pounds. On the 20th of July, I call fire department again. The fire department comes around 6 o'clock in the morning, somewhere in that area. It's the same captain, black guy. So I had told him the story of what had happened at this hospital, the nurse practitioner, the white woman vilifying me because I went there for the pain medication. And he says, well, we can't transport you for pain, for you to get pain medication, but I'll give you a voucher for a cab. Needless to say, first I ain't never heard of it like that. So I was very upset. And in that condition, then he wants to pass me some kind of clipboard. I don't have my glasses. He asked me to sign it, and I did. I don't know what was on it. When I asked them what was on it, they didn't answer me. They got their things. They walked out the door. Next day, I called the VA, which I believe was a Friday. Their triage line, we have to get back to you. All right, so I lay in bed all that day. The next day, a Saturday, I had had enough of this. I have to tell you that the feeling that there was no help there, the misery, the not eating, the not sleeping, I was not in a very good state of mind. Very hopeless. That Saturday, my sister took me to St. Joseph's, and I found out that I had a ruptured appendix, and the approximate time of that ruptured appendix was a week before I went to that previous hospital, 3 weeks prior. So when I went to that first hospital, I had the ruptured appendix. When the fire department came and refused to transport me, I had a ruptured appendix. A ruptured appendix is serious, and it could be fatal. And so, all right. So from July to November, I'm dealing with the drain. They said it had compartmentalized. November 2nd, I go in for surgery. And they released me the same day. I seen some pictures in a folder bedside that showed the inner surface of my abdomen. when they do laparoscopic surgery, they have a camera in there, they take pictures, and the inner wall of my abdomen I could see. And it had a inky looking substance on it. There were 3 pictures. So I go home. And the significance of that is I try to get my medical records and I try to get copies of those pictures. When I go down to medical records and I tell her that there were 3 pictures, the woman gives me a picture in black and white of 1 picture. I said that there were 3 pictures. And she says, the only other picture I have is this one. She gives it to me. But what she doesn't, she's grinning. At the bottom of the picture, there are numbers. And those numbers indicated that she gave me a copy of the same picture. I said, what happened to the other pictures? These are the only ones we got. Really. The significance of that is that they pulled the drain in July. 1st of August, they pulled the drain. It was a percutaneous drain in my abdomen. And by the time I was in surgery, it clearly indicated that they were still leaking in my abdominal cavity. All right, so I go home after the surgery. By the 4th, I'm having severe pain on the left side, not the right side. I mean, I can't even get out of bed. I can't crunch to sit up. And then when I could, with assistance, I couldn't sit on the toilet. I was in so much pain on my left side. Eventually, I go back in. I believe it was 6th. I believe it was the 6th. So I end up in the hospital again for 7 days. They say that the pain that I'm having on the left side, they're addressing by antibiotics for the right side. And then they tell me it appears that they failed to put in a staple, or the staple didn't completely close, but that's on the right side where the appendix is. But the severe pain that I'm having is on the left side. So this goes on. They put in another drain. That drain is in my abdomen until March. I have never been so humiliated in my life. Unlike a colostomy bag that has a charcoal filter that lets the air out, this thing smelled like stool all the time. And whether or not other people could smell it, I could always smell it under my shirt. And I went through the holidays like this. I went for a second opinion in January. I get a second opinion because I'm uncomfortable with this doctor that did it the first time. Let me just add this in here too. When I'm readmitted for that week, this individual comes in with a student doctor. A female, blonde hair. And when they come in, she's palpating, pressing on my abdomen. And she's been a little rough. And, you know, of course she's got my attention now. Now, for some reason, he walks out the room. And I asked her, because I knew, because of her interest in the way she was palpating me and the force in which she was palpating my abdomen, I asked her, I said, You did the surgery, didn't you? And she said, yeah, but he was there. I mean, the alternative is, this is an individual who teaches other doctors, and he screws up with a staple, or by a failure to put one in. So does it make more sense that a student screwed up, or that a teacher of surgery screwed up? Anyway, I mean, this goes on and on. And so I get a second opinion in January. All right, so this person is specifically a colorectal surgeon. And the reason I had to go see him is because now This first surgeon tells me that I have to have half of my colon removed, a right hemicolectomy. And he was real patronizing in his description. Oh, we have to take off a little piece over here and all that kind of stuff. And it was only through my own research and coming back and asking him specific did he finally admit, yeah, right, right hemicolectomy, yeah, and part of the transverse colon, yeah, we have to, because of blood supply and all that kind of stuff. So I go get the second opinion. All right, so I'm scheduled for surgery on the 19th of February. I'm called, surgery scheduled for Monday. I'm called Wednesday. I'm set up with the doctor's office, checked in, and then the hospital calls me, and I'm, they get all the information from me, and I'm all registered and everything for the surgery. And then that Thursday, I get a phone call telling me that I have to pay $300 to the doctor's office. Now, the antibiotics they want me to take is another $100. That's $400. And then they remind me, okay, well, you need to talk to the hospital as well. Now, I'm already checked in. That's what I believe. So I call the hospital, which just happens to be the same hospital that PJ was in. The hospital tells me that I have to come up with $1,700. Well, let me see. Wait a minute. No, $1,300. Because the total I had to come up with was 17. So they tell me I have to come up with $1,300. And I think that was just an estimate of my copay. Because the doctor's office said that we normally get estimated copay on the doctor's services before the surgery as well. And that wasn't the $300 they were asking for. So total, I had to come up with $1,700. By Friday, I'm calling the doctor's office, and I'm trying to get clarification. Because if I'm going to have this kind of major surgery, I'm going to need support from my family, that they're going to have to change all to their activity. So I need to know, because Monday I'm supposed to come in early in the morning and have half my colon removed. And finally, after I expressed the fact that I can't come up with the $1,700, she finally says, well, the surgery is off. I guess it's elective. When you get the money, give us a holler. So, at that point, I'm totally discouraged. At that point, I'm totally discouraged. I go back to see the surgeon, and it's time to just go on faith. And so I asked him to remove the drain. Besides the fact that my pain, which is chronic, has gone on for 17 years, is not being treated, supposedly because they're concerned of my welfare, of overdosing, which I have no history of it, never abused prescription medications. And I think you do somebody more harm physiologically if they are in this kind of pain and it is untreated, and there is a greater risk of moving on to alcohol or street drugs or suicide. They weren't looking out after my well-being. I didn't mean to go off on a tangent on that, but I guess what I'm trying to relate is all during this period, I'm fighting to get the truth about what happened with the accident, the sheriff's department, why the county attorney's office didn't do anything, why the media isn't interested, why we can't get legal advocacy. and exactly what really happened in that hospital, and trying to file these lawsuits myself because we can't get this legal representation. And now my ability to do that is taken from me. And I'm supposed to believe that that's a coincidence. I don't believe that. You know, you can call it paranoia if you want to. But my rights, his rights are taken, our rights are taken, my rights are taken. Dismissed. You know, it's like a battle of attrition. And I'm losing. We're losing. This is a notice of health information practices. Some of you are familiar with the HIPAA laws and the control required over your medical records. When I would go to this doctor, they would give me a document that said that it was an acknowledgement that this hospital is part of this network. It was an acknowledgement. It wasn't an authorization form. It was an acknowledgement. I refused to sign it all the time. However, I hadn't seen this one, this particular document. This document says if you would like your doctor and other health care providers to electronically and securely share your health information to better coordinate your care, you do not need to do anything. What does that mean? It means it's already done. You know, gone are the days where they have to ask for authorization. Now, you have to request that they undo it. And I don't see how they can get away with this. But the key is now you have a nonprofit organization that I don't know how this relates to HIPAA laws, but these individuals can access your records, and a bad narrative at one place now follows you around. You can't go to one provider, have a bad experience, maybe the chemistry is wrong, and then go to another provider. I call it shopping for a provider. Someone that respects you, you can respect, you can trust. That's gone. Because now these negative narratives can follow you around, and the first thing these people read creates an opinion, and now you're getting that same chemistry. It's not objective anymore. So wherever you go, you're going to get the same thing. Now, the question I had is that does that contribute to what I've been going through? Because the primary doctor that I had when I had to switch to go back to the VA had privileges at the hospital PJ was in. And of course, during times that I would go on my visits, I would speak on it. And she was very compassionate, understanding of what I was going through. But when I started finding problems in the records, when I started questioning such things as having I don't want to go off on another tangent, but having an ejection fraction of 33, this is the year prior, and having a cardiac cath done, and the doctor telling me that I had the congestive heart failure and ejection fractions of 33. They had been around that for the prior, since 2009. And for 20 years had left ventricular hypertrophy and an enlargement of the left side of my heart. But I come out of this hospital, the one that I went into for the ruptured appendix, and the doctor comes in and tells me my ejection fractions are 60. no ventricular hypertrophy, and no arteriosclerosis. I, you know, glory hallelujah. But is that reasonable? You know, um, after all this time to have all that improvement. But anyway, um, so I brought those concerns to her, and I started questioning everything after my experience with PJ. And so whether or not these things are connected, whether or not whatever hospital I go to, the doctor that I went to that had scheduled me for surgery, I took him records, but then um, a week later, now it's you have to pay up front here, you got to pay up front at the hospital. You know, I just don't know. But this has been an extremely traumatic experience on his mother and me. It's cost PJ his life. It's affected extended family. And you know, the help that can be done now helps other people. We want to see this through, or we want an independent investigation as to what happened. There is a grieving process. I can't say that I've been able to go through it. It's affected his mother as well. But this is not, you know, I've been beat down a few times in life. But this is the first time I've been beat down by the country I love. I never experienced bigotry, racism, and indifference as I have here. And I think this needs to be exposed. And I hope you will help us do that. Thank you very much for your time. God bless you. Peace be yours.